So today, the presentation that we'll be discussing is titled Major Depressive Disorder, Where Are We Now? Reconceptualizing Diagnosis and Treatment Approaches. To begin, I have no financial disclosures to report. So the focus of today's presentation is to step back and examine where we've been and where we are now in our understanding, diagnosis, and treatment of major depressive disorder. So we're going to explore the history of how major depressive disorder has been defined. We're going to examine skepticism from both the public and within our field, and review the hypotheses for major depressive disorder's diverse etiologies. Through this, we can begin to question and reconceptualize our current treatment algorithms. We're going to split things up into how we diagnose depression and then how that affects how we treat depression. Ultimately, the goal of today is to look forward to envision a future of precision psychiatry where diagnosis, subtyping, and treatment are informed by a deeper understanding of underlying causes and tailored more precisely to the individual. So we'll start things off by thinking about how we diagnose major depressive disorder and how far we've come. The diagnostic criteria for major depressive disorder have changed significantly over the years, reflecting shifts in how psychiatry understands and classifies mental illness. So early editions of the DSM, like DSM-1 and DSM-2, describe depression in vague psychodynamic terms rather than specific countable symptoms and timelines. But starting with DSM-3, in 1980, we saw the introduction of standardized symptom checklists and the formal recognition of major depressive disorder, as we know it today, as a distinct category. Over time, changes like the removal of the bereavement exclusion in DSM-5 have sparked major controversy, with critics arguing that we may be pathologizing normal human experiences like grief. While the criteria have become more structured, they still rely on self-reported symptoms rather than objective biomarkers, highlighting ongoing challenges in accurately diagnosing and understanding depression. So this is where we are now. This is our main tool in diagnosing major depressive disorder with the DSM-5 TR. These are the diagnostic criteria, which I'm sure we are all well aware of, and these are the specifiers that exist currently on the right-hand side of this slide. But not all depression looks the same, right? So major depressive disorder is not a uniform illness. It's highly heterogeneous, meaning considerable variability in symptom patterns, in illness progression, and in the underlying biological mechanisms. We know that it involves interactions among various brain regions and neurochemical systems with different triggers like genetic predisposition, chronic stress, inflammation. And so this has led to the thought that maybe there are distinct subtypes of depression, which is going to be one of the main topics of today's discussion. And we do have those specifiers listed in the DSM that we talked about on the last slide, but they have their limitations as they are symptom-based. And they don't necessarily correlate to specific etiologies or necessarily treatment outcomes. And so we have limitations. We have lots of research, but it's limited by the current diagnostic criteria and being unable to parse out these different subtypes in a reliable way, which then limits the precise treatments and likely hinders treatment outcomes. This has led to skepticism in our field from the public and also internally. So let's talk a little bit more about the skepticism. The extensive research efforts over the past decades have not yielded great success in terms of our first-line antidepressants. So currently used first-line conventional antidepressants are still ineffective for achieving remission of depression for the majority of patients. These are our SSRIs or SNRIs, bupropion, mirtazapine. They have typical response rates of approximately 50 to 60% and remission rates of 35 to 40% after 8 to 12 weeks of treatment. The American College of Physicians has noted that up to 70% of patients do not achieve remission with initial treatment, but most experience some symptomatic improvement. Adverse effects are common, and more than 60% of patients experience at least one side effect, and the tolerability varies between the agents. So some researchers are very harsh, and they argue that the clinical value of antidepressants is very limited, citing these modest effect sizes and the high placebo response rates, and then also pointing to some methodological concerns in the evidence base. And they recommend prescribing antidepressants only when potential benefits outweigh the adverse effects, which I think we all can agree on, but they're a little bit more harsh in their viewpoints. And so that kind of leads us to what the public views, how the public views antidepressants and depression. So we've been seeing more and more controversy over antidepressants, specifically SSRIs in popular media. People in the public have efficacy concerns. They think antidepressants don't even work. Patients state they feel like guinea pigs because of the trial and error of antidepressant medications. They worry about underlying mechanisms of the medications, and they think that we're overprescribing. They bring up the diagnostic limitations, citing that major depressive disorder lacks objective biomarkers, and it's based on these subjective symptom checklists. And this also continues to raise concerns over the overprescribing and overdiagnosis. Critics argue that everyday stress is increasingly labeled as major depressive disorder, and they bring up that expanded diagnostic criteria and the DSM with the revisions and the broadened definitions over the years, potentially medicalizing normal emotional responses such as bereavement. And they worry about long-term effects and discontinuation syndrome. Even internally, we're seeing a lot of discord. In recent years, the monoamine hypothesis, or what is colloquially known as the serotonin imbalance theory of depression, has been revisited, and someone else is now in control of the presentation. Hold on. Thank you. Thank you to whoever gave me control back. All right. The serotonin imbalance theory of depression has been revisited and questioned and ultimately expanded. The landmark trial STAR*D was called into question over lacking a placebo control, and that really pulled the rug out from underneath what guides a lot of our evidence basis for kind of what we see as our algorithms to treat depression. Increasing number of clinicians and researchers call for more critical evaluation of antidepressant use and research design. The former chair of the DSM-4 task force, Alan Francis, he even published a book called Saving Normal, discussing what he calls an insider's revolt against out-of-control psychiatric diagnosis, DSM-5, big pharma, and the medicalization of ordinary life. So what can we do as a field to address this? The conclusions that I've come to are that we are still not that great at diagnosing depression, especially parsing out the differences between the different types of depression. And we're really not that great at treating depression, especially with those first choice medications. I know there are a lot of things that psychiatrists are doing on an individual level to treat depression well, but this talk today is really focused on our current diagnostic and treatment standards as a field. So how can we improve this as a field? How can we improve the diagnosis and treatment outcomes of major depressive disorder? This is where precision psychiatry comes into play, and this is kind of the answer to that question, but then we're going to work a little bit backwards to see really how this could come into play for the future. So precision psychiatry, its aim is to tailor psychiatric diagnosis, prognosis, and treatment to individual biological, clinical, and psychosocial profiles. The field leverages advances in genomics, neuroimaging, and biomarker discovery to identify subgroups of patients and guide personalized interventions. So we're moving beyond those traditional symptom-based diagnostic categories, looking at biomarkers, including genetic variants, neuroimaging findings, and protein markers, which are central to precision psychiatry. And the overall goal is improving diagnostic accuracy and predicting treatment response. And with any new concept that comes, it has its challenges and its opportunities for our field. So not just talking about major depressive disorder with this, but just precision psychiatry in general. It's going to be looking at this boundary between what is a psychiatric disorder and what is normal variation, the boundary between the different psychiatric disorders, parsing out the heterogeneity within the disorders, which we've already spoken about. And then, it has an opportunity to identify people at risk through those genes, environment, and lifestyle factors, maybe even preventing or having early interventional actionable targets. And it really comes down to this concept of precision therapeutics. So we want to match patients to treatments to reduce trial and error. And we want to target the therapies to underlying causes. And the underlying causes of major depressive disorder are what we are going to focus the bulk of today's presentation on, so we can really understand that and how that applies to treatment options that currently exist and ones that are being researched. So let's work backwards to move forward. We have to think about why we think depression happens to think about how to treat it. So the history. So, back in the 1780s and 1880s, this term melancholia came about. This is really what we now know as major depressive disorder, but it had a lot of evolution before it came to that point. So it was first seen as a disorder of intellect or judgment, a partial insanity. Alienation of the mind was a term that was thrown around a lot in this article. And then later is when they concluded that melancholia was really a primary mood disorder, so kind of how we conceptualize the diagnosis today. And they argued that any delusions that emerged from this melancholia were understandable because they were based in that abnormal mood. So you can kind of think about this in terms of how we view cognitive distortions today, and then also especially major depressive disorder with psychotic features. So it's not a primary psychotic disorder or a delusional disorder, it's a primary mood disorder, and then these other symptoms are kind of stemming from that mood disorder. And even back then, they were thinking about the distinct brain structure and function related to depression, which I think is really, really cool because, even in the 1880s, we were wondering, okay, what's going on in the brain and how can we really, figure that out and target that? So that brings us to current day. So I love this diagram on the right-hand side. Take a good look at it. We're gonna take each of these little quadrants, or not quadrants, little, I don't know what to say. And we're gonna take those little pictures and we're going to look at each different hypothesis in different slides and take all of these apart. So presently, major depressive disorder is considered a multifactorial disease with various causes, such as genetic susceptibility, stress, and other pathological processes. Multiple studies have allowed for the formation of these several theories, attempting to describe the development of major depressive disorder. Big caveat, none of these hypotheses are comprehensive because none of them can explain all cases, mechanisms, and symptoms of major depressive disorder. So all of these theories end up sharing some common pathways, which we'll see, and that leads us to believe that these hypotheses depict several pieces of the same big puzzle. The analysis of all hypotheses suggests that brain structures and various substances involved in the pathogenesis are interdependent. This interdependence may not be entirely universal, but it can affect all brain regions to varying degrees depending on the triggering factor, which in turn could explain the different subtypes of major depressive disorder. So as we move along into these different etiologies, we'll be discussing different treatments that correlate with the specific hypothesis of depression, highlighting the tenets of precision psychiatry. Before we dive in, I want to mention the biopsychosocial model, something that we all use in our formulations of patients. And I want to highlight that these etiologies really represent the biological domain of this model, but obviously these domains are not independent. For example, chronic stress and social stressors can trigger biological changes, increased inflammation, and HPA axis activation. And psychological vulnerabilities may mediate the impact of social adversity on neurobiology. So the model emphasizes that effective management and prevention of depression require addressing all three domains. So as we move along, I want you to really keep this in the back of your head. Let's kick things off with the monoamine hypothesis. So as we mentioned earlier, this has evolved, and it includes not only the absolute neurotransmitter levels, as in what was described as a serotonin deficiency, but it's also about receptor sensitivity, transporter function, and post-receptor signaling abnormalities, as well as the interactions between the monoaminergic systems. But the monoamine hypothesis still doesn't fully explain the delayed onset of antidepressant efficacy, the limited response rates, or the effectiveness of non-monoaminergic treatments. So this highlights the involvement of additional neurobiological pathways, which we're about to discuss. When we talk about the treatments using the etiology of monoamine hypothesis, these are mostly your mainstay first-line treatments of major depressive disorder: tricyclic antidepressants, monoamine oxidase inhibitors, SSRIs, SNRIs, atypical antipsychotics, although mostly adjunctive treatment for depression, still work on the same etiology of depression, modulating neurotransmitters. St. John's wort is an integrative treatment, primarily acts through its active constituent hyperferrin, which inhibits the reuptake of not only serotonin, but also norepinephrine, dopamine, GABA, and glutamate. SAMe, folate, L-methylfolate, and B12, they all support the synthesis and regulation of monoamine neurotransmitters through 1-carbon and methylation reactions. The next hypothesis is stress-induced depression. So stress-mediated depression is driven by dysregulation of the HPA axis. So you're going to see this in the next hypothesis as well. It's a very similar pathway. Chronic stress leads to sustained elevations in cortisol and corticotropin-releasing factor, which in turn promotes neuroinflammation and then impairs serotonergic neurotransmission, particularly in the hippocampus, prefrontal cortex, and amygdala. And so individuals with this, you'll see a lot of times comorbid somatic conditions such as metabolic syndrome and cardiovascular disease. And so this is kind of pointed to maybe this distinct subtype of cardiometabolic depression, the co-occurrence of depression and these cardiometabolic risk factors such as obesity, hypertension, dyslipidemia, and insulin resistance. And individuals with this subtype were more likely to be male, have lower educational attainment, exhibit more severe depressive symptoms, especially loss of energy, use antidepressant medications, and demonstrate lower cognitive functioning compared to those with non-cardiometabolic depression. And this really brings up the notion of this bidirectional impact of stress on both mental and physical health. So when we're talking about the treatments for stress-induced depression, I think we're all familiar with how social support and cognitive behavioral therapy, amongst other types of psychotherapies, can be effective for someone with stress-induced depression. Ashwagandha was studied in an 8-week double-blind randomized placebo-controlled trial with patients with a history of chronic stress. They measured stress with a bunch of different scales and cortisol levels. They assessed this at baseline and day 60, and they were randomized to either 300 milligrams of this ashwagandha extract or placebo. And the ashwagandha group experienced significant reduction in all the measures of stress compared to placebo, with a p-value of less than 0.0001, and they experienced reduced cortisol level, a 27.9% reduction compared to placebo. So ashwagandha really points to a treatment modality that could potentially stop that pathway in its tracks of stress-induced depression that we reviewed on the last slide. Exercise also benefits mood in indirect ways. So we were talking about some of the metabolic conditions associated with stress-induced depression, which can be alleviated a bit by exercise, but also activities such as group or team sports enhance social connections and a sense of community and support. And so an exercise routine can also provide structure and discipline, which leads to a sense of accomplishment and improved self-esteem. For nutrition, our understanding of the gut-brain axis has been reshaping the way we approach treatment. And the gut-brain axis is a bidirectional communication system connecting the central nervous system and the enteric nervous system. This pathway involves hormonal, neural, and immunological communication between the gut microbiota and the brain, the vagus nerve serving as the direct link. So the gut has been coined the second brain. Evidence has shown that it plays a pivotal role in regulating mood, cognition, and response to stress, and is linked to the pathophysiology of depression. So good nutrition is very important. And then a notable feature of depressive states is a shift in peak cortisol levels from morning to evening, possibly contributing to sleep disturbances. And so we were talking about cortisol on the last slide, but cortisol is known to be elevated during times of chronic stress, and with the rhythm of cortisol, it's tied to the sleep-wake cycle. So this points to an intricate relationship between stress, cortisol, sleep dysregulation, and depression. And so that's when we can kind of lean into maybe supplements, botanical remedies, mind-body techniques to assist with promoting restorative sleep. Now we'll move into the HPA axis dysfunction hypothesis. And so similar to part of the pathway in the previous hypothesis, when stress activates the HPA axis, the hypothalamic paraventricular nucleus quickly secretes the corticotropin releasing hormone and arginine vasopressin, which triggers the anterior pituitary to release adrenocorticotropic hormone. This then increases cortisol, the glucocorticoids, which release into the bloodstream, and then glucocorticoid receptors are found in high levels in areas like the pituitary, the hypothalamus, and the limbic system. And these regions are essential for cognitive and emotional processing. So to prevent any of this excessive activation of the HPA axis, the cortisol then exerts negative feedback, which regulates the system in the hypothalamus, pituitary, and limbic regions. HPA axis imbalance and elevated cortisol levels have been linked to the development of major depressive disorder, suggesting that maybe glucocorticoid receptors might be an important target for depression treatment. And the research indicates that overactivity of the HPA axis could stem from maybe damaged astrocytes or malfunctioning glucocorticoid receptors, impairing the system's regulation. And then the HPA axis is also closely linked and connected to the hypothalamic pituitary thyroid axis. So you'll see in the image here on the right, cortisol directly impacts thyroid releasing hormone, and then which regulates thyroid stimulating hormone, affecting the thyroid hormones that are crucial for brain function. And then lastly, estrogen plays a key role in cognitive functions such as memory and learning by promoting neuronal growth in the hippocampus, and this also helps regulate the HPA axis. So with this hypothesis, we've discovered a link to what's known as melancholic depression, the subtype. So that's really this HPA axis hyperactivity and this pervasive anhedonia, psychomotor disturbance, early morning awakening, significant weight loss, and excessive guilt. When we're thinking about the treatments for this hypothesis, there are several treatments currently under investigation. So like we just talked about, the glucocorticoid receptor antagonists, they block cortisol action at its receptor, and they have been shown to have modest efficacy for major depressive disorder. Vasopressin V1b receptor antagonists modulate stress-related neuropeptide signaling, and they have also demonstrated promising antidepressant effects in clinical trials. T3, which was notably part of the STAR-D trial, and as you can see by the diagram, is directly implicated in the HPA axis dysfunction hypothesis. Ashwagandha, rhodiola, both been postulated to have HPA axis interactions with cortisol-lowering effects. And we've talked a little bit about exercise, nutrition, and sleep, but I want to talk a little bit more about mind-body techniques such as yoga. So the proposed physiological mechanisms of action for yoga interventions have included downregulation of the HPA axis and sympathetic nervous system, increasing vagal tone and activating the parasympathetic nervous system. And this has been shown in studies where they actually monitored heart rate variability. And then both SSRIs, SNRIs, and then also mirtazapine can lower cortisol. SSRIs can do so gradually over weeks, while mirtazapine exerts a rapid but transient suppressive effect. Next is the inflammatory hypothesis. So chronic systemic and neuroinflammation play a crucial role in pathophysiology of major depressive disorder. Elevated levels of pro-inflammatory cytokines such as CRP, IL-1 beta, IL-6, and TNF-alpha are found in both the peripheral blood and the brain tissue of individuals with depression. Interestingly, among these, CRP and IL-6 show more pronounced increases in females with depression, and TNF-alpha levels rise in both sexes without distinction. Meta-analyses and longitudinal studies support this association, showing that higher levels of these inflammatory biomarkers predict the severity of depressive symptoms and diagnostic status. The cytokines disrupt the monoaminergic neurotransmission, affecting the key neurotransmitters that we know, serotonin, norepinephrine, dopamine. They also activate the HPA axis. And so all of this contributes to the core depressive symptoms that we diagnose: anhedonia, fatigue, cognitive impairment, and disturbances in sleep and appetite. Importantly, for this hypothesis, the relationship between inflammation and depression is bidirectional. So depression itself can exacerbate inflammatory responses, creating a self-perpetuating cycle that complicates treatment and recovery. This cycle is particularly evident in the inflammatory subtype of depression, which is characterized by elevated inflammatory biomarkers and a predominance of the neurovegetative symptoms, and it may respond better to anti-inflammatory interventions. So these immune-related targets are a big area of research right now for depression, using biomarker-based patient selection strategies, looking at cytokines and microglial activation. There are specific ones like anti-TNF agents, infliximab, adalimumab, etanercept, and anti-IL-6 agents such as sirukumab. An anti-inflammatory diet is also very important, so that would include fruits, berries, vegetables, whole grains, leafy greens, legumes, fatty fish rich in omega-3 fatty acids, nuts like walnuts, olive oil, and fermented foods. And these foods are all beneficial because of their high content of antioxidants, polyphenols, dietary fiber, and the bioactive compounds that modulate inflammation and support neuroprotection. Exercise through its impact on lessening inflammation, essentially redirects the metabolism of tryptophan away from a neurotoxic pathway and toward the serotonergic pathway, which leads to positive effects on mood and mental health. And celecoxib, something I'm sure we're all aware of, it's a selective COX-2 inhibitor. By inhibiting COX-2, celecoxib reduces the synthesis of pro-inflammatory prostaglandins and then downstream cytokine production, particularly IL-6 and TNF-alpha. Minocycline has been investigated as well. It's a tetracycline antibiotic with pleiotropic anti-inflammatory and neuroprotective properties. It readily crosses the blood-brain barrier, which is good in this situation, and inhibits microglial activation, which reduces the production of pro-inflammatory cytokines and oxidative stress. N-acetylcysteine, omega-3 fatty acids, probiotics, and vitamin D, a lot of these go along with that inflammatory diet. Some of them can be found in foods themselves or be taken as supplements, but all have demonstrated to be good adjunctive treatments for major depressive disorder by targeting neuroinflammation. And then SSRIs and SNRIs have demonstrated anti-inflammatory effects, just not exactly to the same extent as some of these other research targets. And then acupuncture is a different kind of model of treatment as well. So the proposed mechanism of action there is that it involves modulation of molecules such as opioids, the cytokines, and neurotransmitters. And its potential impact on depression is attributed to its ability to reduce neuroinflammation and enhance brain-derived neurotrophic factor BDNF expression in the hippocampus, thereby conferring a neuroprotective effect and then stimulating neuroplasticity, which leads us into our next hypothesis. So this is the neurotrophic brain remodeling hypothesis. And this hypothesis also starts off with chronic stress. So I think you're going to start to see a theme here and how all of these are interconnected. So chronic stress elevates the glucocorticoids, which we've discussed. And another effect is that it suppresses BDNF, which impairs neurogenesis, and then disrupts the negative feedback loop in the HPA axis. So some terminology here. TRKB, short for tropomyosin receptor kinase B. It's a transmembrane receptor protein, and it plays a crucial role in the development and functioning of the nervous system. Its main role is because of brain-derived neurotrophic factor. So it's a high affinity receptor for brain-derived neurotrophic factor, BDNF for short. That is a vital growth factor for neurons. And it's highly expressed in the central nervous system, essential for neuronal survival, differentiation, and synaptic plasticity. And so through all of this, depression and chronic stress are associated with the impaired synaptic and structural plasticity. We see this with imaging findings and data that shows us reduced spine density in hippocampus, medial prefrontal cortex, medial amygdala, and then increased spine density in basolateral amygdala. And then in treatment-resistant depression, there are specific areas of the brain that are looked at. So some show reduced functional connectivity within the default mode network, which includes the medial prefrontal cortex, the posterior cingulate cortex, and the precuneus. So this leads us to talking about treatment-resistant depression and, kind of bringing up the idea of, is this really a misnomer? Is this a subtype of depression, or is this really a progression of depression? And the prominent symptoms are anhedonia, amotivation, and there's a lot of controversy that exists over those neurobiological changes. So some people think that it's a unique subtype of depression and that so certain brains have these brain changes. And other people think that it's really just a progression of major depressive disorder, that we haven't been treating depression in the correct way, and then it leads to these brain changes over time with a brain that has been depressed for a considerable amount of time. And so when we're thinking about treatments, SSRIs, SNRIs, bupropion, lithium, atypical antipsychotics, they all increase BDNF levels and promote neuroplasticity, but they just don't do it as well as some of the other treatments on this slide. I put exercise up there, so studies have found that physical activity increases the size of the hippocampus, which is important for memory, learning, and emotional regulation, and it's thought that aerobic training improves hippocampal perfusion and could be effective in reversing some of that hippocampal volume loss. And, we just talked about treatment-resistant depression, so you're going to notice a lot of these treatments are some of the current FDA-approved treatments for treatment-resistant depression, which I believe is no coincidence in their mechanism of action related to the etiology. So ketamine, the FDA-approved S-ketamine nasal formulation, that produces a rapid and robust upregulation of brain-derived neurotrophic factor and neurotrophic brain remodeling. And it has a faster onset and greater magnitude of effect compared to the other medications listed on the slide. TMS, transcranial magnetic stimulation, specifically rTMS, also increases BDNF, promoting that brain remodeling. And ECT, electroconvulsive therapy. This is, one of the main reasons that it's so effective, and it has a faster onset and more robust action than some of the other treatment modalities, is because of its increase in BDNF levels and promoting of the neurotrophic brain remodeling. And then acupuncture, we talked about a little bit on the last slide, but it does potentially enhance BDNF expression in the hippocampus. All right. The circadian hypothesis of depression, a little bit different than the rest of these. So this one is more unique. So it's involving disruptions in the body's endogenous circadian rhythms. So with that, we're talking about sleep-wake cycles, hormonal secretion of cortisol and melatonin, and core body temperature. And then these disruptions lead to the development of depression. So stressful life events, looking at that diagram on the right, all the way on the right, those can shift sleep schedules. So this disrupts our molecular clocks in our cells and then can trigger mood disorders in genetically vulnerable people. Zeitgebers, that's external environmental cues. So light, social interactions late at night, meal timing, physical activity late at night, things like that. Those can affect the chronobiological alterations. And so at a molecular level, genes that regulate circadian rhythms, particularly the ones in the brain regions like the anterior cingulate cortex, have been found to be dysregulated in major depressive disorder. And we also see sleep phase advances in both cortisol and melatonin rhythms in depressed patients. And so chronic sleep loss actually increases inflammatory markers in the blood, which may further heighten the risk of depression. So you can see how some of this is all connected. And from a neural perspective, the brain circuits involving the dopamine neurons, serotonin, orexin, and then the locus coeruleus amygdala pathway are all influenced by the circadian processes. And so the disruptions can impair mood regulation, fear, learning, reward processing, and a lot of these are core issues in depression. So I think we're all familiar with a seasonal subtype of depression, but that's really, what we're looking at here. So it's due to circadian rhythm disruptions triggered by changes in the environmental light exposure, and then the impairment in the adaptation to the sleep-wake cycles. So when we're thinking about precise treatments here, I think a lot of us are familiar with bright light therapy for that seasonal depression. Interestingly, sleep deprivation therapy has been shown promising results because it rapidly reduces depressive symptoms in studies. And so the thought process is that maybe it's resetting the disrupted circadian rhythms by depriving sleep and then kind of resetting those processes. Cognitive behavioral therapy, specifically for insomnia, is very effective. The therapies such as interpersonal and social rhythm therapy, melatonin, in that pulsatile fashion, Ramelteon, which is a melatonin receptor agonist. And then I put on here agomelatine. It's not approved in the US, but it is an atypical antidepressant approved for treating major depressive disorder in adults in other countries. And that's because it acts as a melatonin agonist and a 5-HT2C receptor antagonist to resynchronize those circadian rhythms, improving sleep, and then also increasing norepinephrine and dopamine levels. So another study is kind of showing us more of how GABA and glutamate could be implicated in depression. And so recent studies in animal models and human subjects have suggested an association of the glutamatergic and GABAergic systems within the pathophysiology. And so we see reduced expression of the receptor subunits, imbalances in the levels of those themselves, decreased glutamatergic and GABAergic neurotransmission, and then altered energy metabolism. And so these reduced GABA concentrations and GABA interneuron deficits in the prefrontal cortex, anterior cingulate cortex, and other regions have been shown in individuals with major depressive disorder. And the GABAergic deficiency is thought to result in the disinhibition of the glutamatergic neurons, which potentially leads to altered glutamate release and then synaptic dysfunction. And so we see glutamatergic abnormalities also implicated with the studies showing altered glutamate and glutamine levels in the medial prefrontal cortex and the anterior cingulate cortex in those patients with depression. And so this kind of leads to what I'm sure a lot of you thought I was going to talk about today, which is postpartum depression. And so basically the gliopathology and neurosteroid dysregulation may contribute to the GABA deficits that are implicated in hormonally mediated mood disorders such as postpartum depression. In postpartum depression, there's evidence of reduced GABAergic signaling or altered GABAergic signaling, which is partly attributed to that huge peripartum fluctuation in neuroactive steroids, such as allopregnanolone. And allopregnanolone is a potent positive allosteric modulator of GABA receptors. And so basically in the postpartum period, these neurosteroids undergo a rapid decline, and then it's thought to be failure to adequately restore the GABAergic tone that's implicated in some of the development of postpartum symptoms, which we'll talk about in our treatments on the next slide. So that's how they kind of came up with some of those newer medications for postpartum depression. Some people might have heard about brexanolone, which was the IV infusion version of the postpartum depression treatment. That's actually been taken off the market. It was more of a proof of concept medication so that they could come out with the oral medication, zuranolone, which is a neuroactive steroid. So it's working on this model of GABAergic transmission. And so they're allopregnanolone analogs. They serve as positive allosteric modulators of GABA A receptors, and they enhance both phasic and tonic GABAergic inhibition. And they have rapid antidepressant effects, which I've seen in practice. And then also in this category would be ketamines or intranasal esketamine. It's an NMDA receptor antagonist, so it has rapid antidepressive effects by modulating the glutamatergic neurotransmission and synaptic plasticity. And then psilocybin, which is investigational for depression, primarily as a 5-HT2A receptor agonist, can lead to increased glutamate release in the prefrontal cortex and hippocampus. And then the glutamate surge stimulates GABAergic neurons, resulting in increased GABA release, which then can rebalance that excitatory-inhibitory neurotransmission balance. Auvelity has, it's a combination drug, so it has both the glutamatergic and the monoaminergic mechanisms there. And then, there's investigational glutamatergic agents out on the market. None of them have been named, so I don't have any names to give you, but that's something that research is really going for right now. Physical exercise has been shown to acutely increase the cortical GABA and glutamate levels in humans, and then regular exercise upregulates those GABA receptor subunits, reducing the neurodegenerative processes associated with the GABAergic dysfunction. Dietary interventions such as the ketogenic diet may increase central GABA levels and then help rebalance that GABA glutamate signaling. Last but not least, we're going to talk about the genetic implications for depression. And so, we don't fully understand the causes of major depressive disorder, obviously, but research always highlights a strong genetic component. And studies suggest the heritability ranges from 30 to 50%, which is substantial. There's over 100 gene loci that have been linked. We haven't gotten one specific gene target that seems like it's going to, apply to everybody, but there's a lot of different gene targets. And overall, the genetic factors play a role, and they only account for part of the risk. So it's, a combination of genetic predispositions and environmental stressors that seems to be the most important for the development of major depressive disorder. So with this, histone deacetylase inhibitors are experimental agents targeting the epigenetic dysregulation in major depressive disorder. So they increase histone acetylation, promoting the transcription of genes involved in neuroplasticity, neurotransmission, and stress response. So it's not currently approved for depression, but it's definitely an area of research looking at this genetic hypothesis and how we might utilize that to our advantage. ECT, as we already talked about, upregulates BDNF and signaling molecules, but it's also accompanied by epigenetic modifications that regulate gene expression. Folate, especially in its bioactive form L-methylfolate, which is required for the synthesis of serotonin, norepinephrine, and dopamine. This is important because, as I'm sure you've heard in popular media, genetic polymorphisms in the MTHFR gene can impair conversion of folic acid to L-methylfolate, which would then reduce the CNS monoamine synthesis and then increase depression risk. And then SAMe also has a role in supporting the synthesis of the neurotransmitters and then the epigenetic regulation of the gene expression as well. And then I think, we all know that medications that were effective for family members might be effective for our patients, and that is pointing to a genetic link there. And then pharmacogenomic testing, which I know has been controversial in our field, but it does kind of point to some of these genetic variants in terms of the metabolism. So for the cytochrome P450 enzyme variants, which can be used to guide antidepressant selection because of the metabolism rather than because of the disease pathogenesis. So what do we do with all this information? That was a lot, right? So thanks for bearing with me with that. But based on these different etiologies, there are different preferred treatments, right, for depression based on the etiology. But it's not always easy for us to just by a clinical interview and a symptom checklist to really get to the etiology of depression. We have that biopsychosocial model, right? And that helps us guide us in some ways. But now that we have decades more of information on the potential etiologies past the monoamine hypothesis, why aren't we using them? So, I kind of want to bring our attention to some of our current treatment algorithms. I know that the word algorithm isn't always, seen as a good thing, but these are the things that are guiding how we really, look at depression for first-line agents. And so we have the APA, the VA up to date, and the Oregon Health Authority, which has some good online resources. But basically, it's saying to look mainly at maybe if they've responded well to something in the past, but for initial pharmacotherapy, we're looking at SSRIs, SNRIs, bupropion, mirtazapine. They say, again, in this one, same agents, and then, based on patient preference, safety, they do say to look at those, the pharmacological properties with the cytochrome P450 enzymes, cost, other co-occurring conditions. Then, okay, maybe we need to augment, maybe it didn't work right away. What are we going to do next? Maybe we're going to augment with a second generation antipsychotic. Maybe we're going to augment with bupropion, switching, augmenting, T3, the STAR-D trial, lithium. These are all kind of different ways that we can go about this. But as we've kind of discussed, those are all really in the monoamine hypothesis. These aren't really necessarily targeting specifically those other etiologies. Changing to other treatments, like we talked about, you have partial response. Maybe you can add something, you can augment, you can switch to something in a different class or in the same class. And then augmenting with psychotherapy, obviously. And then when we get to treatment-resistant depression, then we start adding in ECT, TMS. The VA also mentions esketamine and the vagal nerve stimulation. This is a really cool diagram for the algorithm, but basically highlighting what we've already spoken about, where we start with SSRI, SNRI, bupropion, and mirtazapine, and then we kind of go from there based off of if it works, if it doesn't work, if we want to add something, all of those things. So we know that only about a third of patients will achieve remission with their first antidepressant, but what if we could be more precise in the options that we propose? Or what if we could use data based on the etiologies to predict treatment response? And that's where we get back to precision psychiatry. So this is really where we get into, the point of today's talk of reconceptualizing the diagnosis and treatment of major depressive disorder. This is the future, in my opinion, of psychiatry, is precision psychiatry, with the goal being to differentiate and categorize patients for better diagnosis and treatment outcomes. And so these are some of the future directions. So, there is evidence for differential responsiveness based on the symptom clustering, but we're kind of moving past that with precision psychiatry. We're using that, but we're using other things as well. So you can use neuroimaging through resting state fMRIs, biomarkers, all of the hypotheses that we talked about have biomarkers that you can measure and try to figure out if there's some sort of pattern there. Dimensional brain-based predictions, so utilizing EEGs. AI can help assist with prediction of treatment response through analyzing past charts. Systems biology and computational psychiatry, so creating this biosignature for a patient. And this really goes hand in hand with the research domain criteria, or RDoC framework, that was developed by the National Institute of Mental Health. So you can see in this diagram on the right, this is the framework. It provides an approach to research that views mental health and psychopathology in the context of the major domains of basic human neurobehavioral functioning. So instead of using the symptoms or signs for disease state definitions, it goes past that. It incorporates a little bit more things, and it reverses, the perspective by considering psychopathology in terms of deviations from normal functions that account for the particular symptoms. And this is where we are trying to identify these endophenotypes, or these biologically grounded subtypes, by integrating the data across these multiple domains, which is the central model for precision psychiatry. And this is a really cool graphic putting it all together for precision psychiatry. So you can see through all of the different domains that are trying to be pulled together to create this biosignature for a patient, which then can lead to this paradigm shift where instead of we're doing this trial and error thing with our patients, we can have a little bit more of a precise diagnosis and a precise treatment outcome. And so this approach leverages all of these multi-omics, which you see on the left-hand side of the diagram. Those are the omics, and systems biology to uncover complex interplays, such as between what we talked about today, the immune dysregulation, neuroplasticity, neurotransmitter systems, genetic variants. And so by understanding these interactions, the researchers can identify more specific and reliable biomarkers, which can then help us predict treatment response, stratify patients, and then guide personalized interventions, rather than relying on broad diagnostic categories or singular molecular targets, which have not been proven to be very effective in the past. And ultimately, precision psychiatry aim is that therapies are tailored to the individual's unique biological profile, and this is obviously with the hopes of improving efficacy and reducing treatment failures. It also opens the possibility for these novel drug targets, and then repositions the existing medications that we talked about today based on the mechanistic insights, allowing for the development of new algorithms and new clinical tools that is based on the subtypes of depression. And in this way, precision psychiatry can transform the diagnosis and treatment of major depressive disorder from a trial and error struggle into a more precise and evidence-based approach. To help this vision come to fruition, we need continued research, bold ideas and thinkers, collaboration across the disciplines, and we need to challenge assumptions and really think outside of the box. So thank you all for your attention today. I now welcome questions or comments about today's presentation, and I do want to say a special shout out to some amazing, intelligent, supportive people who helped me along the way with this presentation, including Dr. Hamzi, Dr. Kalibi, and Dr. Sullivan. So with that, I say thank you for your attention. And here are my references.